Heymann. With your vast experience, do you feel that the lessons learned during SARS and MERS-CoV, as well as Ebola, have helped prepare the world to a certain extent in responding to the current pandemic, especially with, big data being present and being able to track information live?
Well, we use big data every day, so it's normal that we would be using it in the current pandemic. We use big data every day for global surveillance of influenza, for example. Laboratories around the world collect viruses that cause influenza, and they provide them to centers where they're genetically sequenced. And those genetic sequences are then stored in a digital database that can be accessed by public health workers and by people determining what's necessary to have in each seasonal influenza vaccine. The same is true for polio. Polio has clearly been eliminated from Malaysia, but there is still global surveillance of polio to identify the genetic sequences of polio viruses that exist, because in effect, that data can be used to track where people are who are infected. At the same time, there are databases that are used for people who have cancer, because there are databases that have cancer linked to human genomes, to human genetic sequences that can begin to show what are best treatments. So there are many, many different ways. In fact, Anita, if it would be useful, I could show some slides which would give an example of some of them.
Go right
Would
ahead,
that be
Dr.
useful?
Heymann. Yep.
Okay,
Yes, please. Yep.
let me see if I can get some slides here that would show you a little bit about what goes on in data.
Yep, we got it.
Okay, let me make it bigger for you. This is a slide which shows the data, the genetic data that's used on polio viruses. This data is stored in a central depository that's managed by the World Health Organization. And what you can see here in Pakistan at this time is the way that the virus spread from one area to another. And this is known because of the genetic sequences of this virus that have been stored, and of all viruses that are known in polio. And by knowing what virus is in one part of a country, if it goes to another part of the country, you can tell that by a genetic database. So this is a big data database looking at polio eradication. This is a very interesting system which is developed here in the United Kingdom. This system is looking at what's called syndromes. That means it's looking at things like signs and symptoms of influenza, fever, or signs and symptoms of vomiting. And this data is collected by an automatic search every 24 hours of all the information in the National Health Service emergency departments and in the NHS call-in system. So that if there is a cluster of vomiting, such as is shown in the right, where you see it's in the red, immediately when that red is identified, there is then, after that, an investigation to see exactly what's going on. This is another, go ahead, Anita.
I'm sorry, Dr. Heymann. Is that in general,
Yeah.
are those symptoms specific to COVID-19 or just in general, like influenza?
These are symptoms in general, but what would happen was, and what did happen was, on the left are signs and symptoms of cold and influenza. And those signs and symptoms actually triggered an investigation, and it was found that there was COVID-19 occurring early on in the United Kingdom. So these systems are in place all the time. Every 24 hours, there's a printout like this barometer, and it shows when there is an event which is occurring. The ethical use of big data in big data platforms. I'll go on to this one more, which I think is very appropriate, because this is what Hong Kong did during the SARS outbreak. What Hong Kong did was it entered all the data of people who were found to have SARS infection, and it put in all the information of where those people had been during the previous 24 hours. And what you can see here on the left is that every morning they printed out a printout that would show where there might be clustering of people who had signs and symptoms. And on the left, you can see circled a cluster that was printed out in this big database. And on the right, you can see the investigation that occurred at that cluster. And it showed that a Chinese restaurant in Hong Kong was responsible for the transmission of infection to all those different people. Hong Kong was then able to rectify the situation at that restaurant and move ahead with their control measures. So I just wanted to show a few of those to show what big data really does, Anita. Back to you.
That's really interesting. In that it's really live information as well. I think that's fascinating. Um, for a country to have this data and use it for the benefit of the nation, um, how important is or how far a gap is the lack of infrastructure being developed between developed and underdeveloped countries or developing and developed nations? For example, in the US, where big data is very much in its advanced stage, it is the number of, it is a country with one of the highest number of cases and death rates. So what went wrong?
Well, big databases are only that. They're big databases. And if they're not used in the best possible way, they don't help in dealing with an outbreak or with any issue. And what appears to be happening in the US is that the Centers for Disease Control, which is where I spent my career, seconded various parts of the world, but from there, the Center for Disease Control today is not leading the response in the United States. Normally, it does lead the response, as it did for the swine flu H1N1 pandemic back in 2009. But presently, it's not leading the response. And therefore, in the United States, which has a decentralized health system and a decentralized public health system, states are in control. And the Center for Disease Control, which usually works behind the scenes with the states through state epidemiologists, is not doing that at present. And so states are more or less on their own doing what they feel is necessary. And unfortunately, in the US, this has become a partisan issue between Democrats and Republicans.
It really has. And I think Dr. Fauci's hands are tied in a lot of ways.
Absolutely.
Let's move on to China and the rest of the world. So early on in the outbreak, China implemented, and they were very swift in their response as well. They implemented intense measures to keep people physically distant. Severe lockdowns and other restrictions in attempt to slow down the spread of the virus. And according to a study published recently in Science, those measures succeeded. In less than a month, the daily number of new cases in China had leveled off and has since slowed to a trickle. However, in the United States, where measures to keep people physically distant from each other were in place for a month or more, obviously we know that there were demonstrations and other aspects that were thwarting that effort. Depending on the state, the outbreak had slowed, but it's certainly, it's far from a trickle. What do you think China did right in terms of, in terms of that and in keeping the pandemic under control, and how has data come into play? What are the factors that that contributed to this, and where is it that other nations, like every other nation, can learn? As it is at the moment in Malaysia, our cases are on the rise from two very virulent clusters in two different states, and so it's always very relevant. I think the world is looking at a second wave globally.
Well, it's been very interesting to see the response in various countries around the world. As you said, China had a very severe measures. They put in place very severe measures, which many countries would not be able to do, but they were able to decrease transmission to a very low level by doing that. So they used measures that were a lockdown, physically keeping people in their homes and making sure that there wasn't transmission in the communities. Other countries have done variations of that. Countries in Asia, such as Malaysia, such as South Korea, Hong Kong, Singapore, and Vietnam, have really taken an epidemiological approach. They've not locked down entire economies in most of those countries, but what they did was they found out where transmission was occurring. They locked down those areas and then they unlocked them after they had rectified the situation. So South Korea, which had major outbreaks associated with religious groupings, were able to contain those outbreaks very rapidly because they were doing contact tracing and understanding how they could prevent transmission from continuing. In other countries in Europe and North America, they've had just blunt lockdowns, locking down the entire economy, and they thought that that might be enough. And they did indeed decrease the burden of patients into their hospitals. But at the same time, many of them didn't have an exit strategy. And so now, as they're leaving this lockdown, they're seeing that cases are surging. It won't be another wave. It won't be an entire worldwide wave that occurs with influenza, because this doesn't transmit like influenza.
Yeah.
This transmits in clusters that can be stopped, and as you've seen in Malaysia. So what's going on now is that countries are beginning to understand that and trying to deal with resurgence when it occurs.
Thank you, Dr. Heymann. That's quite clear cut. In both national and global epidemics, big data has advanced to a place where it can provide emergency response teams with real-time tools and technology. And that gives them the ability to monitor, contain, and even stop the spread of the disease. In Malaysia, we've implemented, as you know, the My Sejahtera app. It literally translates to My Harmony, and it's interesting because My is kind of a play on Malaysia and the English My, and it collects personal data from downloaders and users of the app: contact number, email address, full name, identity card number, age, gender, ethnicity, and home address. That was developed with the intention of helping the Ministry of Health with COVID-19 clinical and epidemiological analysis. In Sarawak, the state also uses the State Disaster Management Committee. In fact, they're quite unique in that way. How can we, in times of crisis, comply with data privacy regulations? How would you recommend governments to ensure that the data is used ethically? As you said earlier, I think you mentioned that kind of board, a very inclusive board. But also, what is your advice to governments, and how to strike balance between whether it's state or federal governments need to collect data and trust, as we spoke about?
Well, I think it's very laudable. It's very good that Malaysia has developed an app, because it's very important to see how far we can go with digital technologies and how helpful they will really be. And I'm sure that Malaysia is, in addition to having developed this app, taking a look to see how effective it really is, because this is the future. Digital is the future. Big data is the future, and we need to learn how to manage it in the right way. I don't know a lot about the app being used in Malaysia. I've read a little bit, but I haven't really grasped it completely. But if it is a voluntary app that people download, then they understand when they download it what the risks are, or they should understand those. And
it is made compulsory for those who have to do quarantine as well. So for those who are quarantining, based on policies, depending on their travel history and their symptoms, then it's made compulsory.
Yes, it's made compulsory in many other countries as well, in Singapore, for example, in other countries. And this fits in with the ethical discussions in that country. That might not be acceptable in some other countries, but in countries where there has been a discussion about whether or not this is ethical, and I'm sure that's occurred in Malaysia, it should be used. It should be used as a way of trying to deal with the outbreak. I myself am in London, and I'm in self-quarantine in London because I traveled here a week ago, and I've been in self-quarantine for 2 weeks. I'm being monitored. People call periodically to see if I'm at home. This could be considered intrusive by some people, but it's the way that the system works today. And so anything that's within the ethical realm of a country is what should be used, and people should understand that. So if Malaysia has a good ethical framework around what they're doing, then there should be no worries, and data should be managed in the right way.
Thank you for that, Dr. Heymann. Let's talk about the hot topic, vaccines. There are currently over 169 COVID-19 vaccine candidates under development, with 26 of them already in the human trial phase. How is big data being used to accelerate clinical trial for vaccines?
Well, big data is extremely important in clinical trials because, especially in this instance, people need to understand whether those who are vaccinated are getting infected or are getting sick. And they need to compare that to a group of people who aren't vaccinated to see what their rate of getting infected or getting sick is. So these trials are very complicated, and they depend on big databases. Those databases must be treated with confidentiality because individual patients' information is important. But you can't replace databases in a study like this with anything else. It's required that those databases be used so we can have rapid analysis of the data and rapid use of that data. So if there is a vaccine that's been shown to be effective in either preventing infection or modifying infection once a person is infected, then that data has to be available rapidly so that the licensing can be done rapidly.
What's interesting here is the fact that, as you said, for privacy reasons is and proprietary concerns as well. I mean, what would be interesting if big data being data and useful information, especially in the fields of health, could be shared with an anonymity.
It would
You know,
be.
yeah, that I think that would be ideal, but unfortunately, can you shed some light as to how this is not au fait?
Well, it's not occurring as much as it could because of proprietary reasons, as you've said. Companies are investing in research and they want to see a profit. So they're not at many times willing to share all the data. But there is a movement under the Wellcome Trust, which is one of the world's largest health foundations, and other groups to try to get the pharmaceutical industry to share databases with public health workers. And this is very important, for example, in antimicrobial resistance against antibiotics. Drug manufacturers are keeping a lot of data because they're seeing what's happening to the drugs that they've developed. And many times this data isn't available to public health people. So there is a movement to try to get more relationships between the public health community and the databases that industry manages.
I'm for that. Are you for that, Dr.
I
Heymann?
am for that, yes. Anything that will improve public health.
Um, let's move on to the topic of telehealth. Now, to mitigate some of the logistical problems created by the pandemic, is to transition to telehealth services when possible, and that's not a new thing for a lot of nations, where it allows patients and families to consult with physicians using computers or via phone. Yeah, can you shed more light on telehealth? What are some of its pros? What are some of its cons? And how it can be critically useful at this time?
Well, telehealth often works by a call-in number where a person who is feeling ill calls in. Sometimes they are asked to give their signs and symptoms. And then the person on the other end of the telephone can take these signs and symptoms and fit them into an algorithm that tells them where to refer that patient. If the patient goes through the algorithm with its signs and symptoms and has something which needs to be seen by a doctor, then the patient is referred to a doctor, sometimes by telehealth, sometimes by going directly to the office. If the signs and symptoms are not proven to be very serious, then sometimes the patient is just given advice about what to do and told to telephone again if those signs and symptoms don't disappear. So that's the initial triage. That's the way that patients can enter into a telehealth system. Telehealth systems are very useful. There are some that are very interesting. For example, there's one called Flu by You, which is taking information of people who have signs and symptoms of influenza. They send it into a common place, and then they receive back information about where influenza is occurring in their neighborhood, but also they're told if they have signs and symptoms where they should go to be treated, and also they're told to go get a vaccination and where to get a vaccination if it's necessary for them. So telehealth is opening up many, many new ways of working, and it's very useful moving forward. But it doesn't replace that contact of a patient with a doctor, because that's also very important. And one day, maybe with a digital generation of young people coming up, they won't demand that attention that the generations today demand, which is personal contact with a doctor. They may say, we don't need this anymore. Who knows what will happen in the future?
This is true. I mean, everyone would rather do it over Zoom. Um, well, in that
Like we're
generation,
doing.
yes. Well, we're limited. We're limited. Otherwise, I would have very much loved to be and meet you in person. Um, let's talk about one of the key things that you are propagating in your discussion about how the WHO is now going towards advising governments to learn to live with the virus. Um, you were in a online weekly roundup meeting at the International Livestock Research Institute in August, and it mentioned that already then that the world needs to learn how to live with COVID-19 because it's likely to become endemic, and vaccines, as we know, will take some time. Um, could you share with our audience what are the key steps for individuals and companies to take to ensure continuity while keeping public health?
Well, thanks. Yes. Just to give a little bit of background, Anita, I chair a group at the World Health Organization called the STAG-IH. It's the Strategic and Technical Advisory Group on Infectious Hazards. And we're working with the World Health Organization Emergencies Program, meeting twice a week for 2 hours during the current COVID pandemic. We've been able to review data from many, many countries around the world, public data that's provided by the countries to our group. Countries come in on Zoom to the group and talk about what they're doing. And our conclusions are that we need to learn to live with the COVID pandemic using the tools we have today. And we have many good tools that we should be using today, including diagnostic tests, which can diagnose when someone is infected and can also tell if people have been infected in the past. And these need to be used along with other means within countries, including outbreak investigation, including contact tracing and outbreak containment, in order to begin to better live with COVID-19. So what are some of the measures to use? Well, number one, we need to make sure that the elderly populations and those populations who are at risk of serious illness if they get infected are protected. They need to know how to protect themselves. They need to physically distance from others. If they're in a care setting, in a healthcare setting, then they need to be in a setting which is secure from infection. At the same time, they need to understand that if they can't physically distance, and this goes for everybody in the population, if they can't physically distance, they should wear a mask. So if I'm getting on a train or on some other public conveyance, such as a bus, and I can't physically distance, I should wear a mask to protect others in case I'm infected. That mask will not protect me because eyes are also a point of entry of the virus droplets. So the mask wearing is to protect others. The physically distancing and washing of hands is to protect oneself. So that's one thing that's very important. Populations have to play a role in this. At the same time, there need to be other measures, including good contact tracing and making sure, above all, that business is involved in this, that business has secure places for people to work, and at the same time is part of the government's response and providing input to government decisions.
Gotcha. Thank you, Dr. Heyman. We've actually got a few questions coming in from the floor already. So we'll take a quick break to that. And there were some audio issues in being picked up in the hall earlier. So we'd just like to acknowledge once again that we are in the presence of the Right Honorable Chief Minister of Sarawak, Datuk Petinggi Abang Johari, as well as the cabinet, honorable cabinet ministers of Sarawak, including the Deputy State Secretary, as well as the Sarawak Multimedia Authority and the organizing committee from Scope. We do have some questions, and so we would like to toss over to Farah, who is on ground and on site, to pick up some of those questions.
Thank you very much to our moderator and speaker. And now let's proceed with the Q&A session. So once again, we'd like to invite our delegates here at BCCK to come forward. All right, we open up the floor to any questions. Silakan. Let's have the first question up. Silakan.
Hi, I'm Shazad. I just would like to find out from David Heymann with regards to tourism. You know, I'm from the Tourism Board. With your past experience, do you feel that the lesson learned during SARS and MERS, as well as Ebola, have helped prepare the world sufficiently, you know, and to respond to the current pandemic, especially with the assistance of big data? I really would like to know, because, you know, it is really affecting tourism industry. Thank you so much.
Absolutely, yes. The tourism industry has suffered greatly in this pandemic. I think the answer to your question is that the countries that had MERS or SARS outbreaks previously, and that includes many countries in the Asian region, have done quite a good job in applying what they learned during that period of SARS or MERS. They've learned between the period of those outbreaks and the present what they need to do, and they've done it. They've increased the capacity of hospitals to deal with patients who have an infection such as this, and how to isolate them and manage them in a good way so that they survive the infection. At the same time, they've developed rapidly applications which they can use with big data to try to understand where disease is coming from and how to stop it and how to shut it down. And at the same time, to help people understand if they've been in contact with someone who's been infected. So Asian countries in general have a sustainable way forward. They've been able to rapidly apply what they learned and what they have done to prepare during the interval between SARS and MERS corona outbreaks and the current outbreaks. I would say that countries in Europe, countries in North America and South America have done less well in being prepared for this outbreak for some reason or another, and they were caught off guard. Whereas countries in Asia, as soon as WHO announced on the 5th of January that there was something going on in China, countries immediately began to look, and as early as the 20th of January, Singapore, for example, was already stopping outbreaks which were occurring. They knew that this was a risk to their country. Coming to tourism and travel, it's a very difficult issue to address in person. As I said, I'm here in self-quarantine in the United Kingdom because what they require is if you come from a country where they feel there's greater risk of transmission than in the United Kingdom, then you must self-isolate for 2 weeks. So I'm self-isolating. The way that countries are determining this is a database which is reporting cases of coronavirus to the World Health Organization. In looking at that database, though, it's really not a valid database for making such comparisons, because what's happening is countries are reporting positive tests. Those are not cases, those are positive tests. And those tests are developed, or those tests are done using many different testing strategies. In many different countries, the testing strategies are different. So whereas that data is good for determining trends in countries that continue to use the same testing strategies, they're not useful for comparison internationally. And so actually this coming Friday, and then again next Tuesday, we'll be meeting with the World Health Organization in the committee that I chair, in the group that I chair, reviewing this and trying to help work with WHO to develop better indicators which will permit countries to understand when travel might be safe, because countries are looking for equality. They're looking for an equal risk of infection as they travel between countries and an equal risk of response capacity in countries so that they can stop outbreaks and deal with the pandemic. I hope that's been helpful. If not, I'm happy to answer more.
Thank you very much, Dr. David Heymann. And yes, we're picking up another question from the floor, please. Silakan. All right, Dr. David Heymann, so we have this one question, all right, coming from our webinar video conference of viewers, all right, as this anonymous attendee, he said, you mentioned that we need to start living with COVID. I understand that there is no silver bullet out there, nor should we rely on a vaccine as one. But what do you think are the top 3 things governments can do from a policy perspective to reopen borders? And do you still stand by the WHO's recommendation that borders should not be closed? Dr. David Heymann.
Thank you. Yes, closing borders can give a false security that you're protecting your country. And the reason that closing borders doesn't work in this instance is for several reasons. Number one, the PCR test, or the test that we have to detect virus, detects virus only a certain number of days after a person becomes infected, and that varies from person to person. So if a person is, if a country is using a PCR test as assuring itself that someone coming into the country is not infected, it's not a valid way of doing that. At the same time, people who have COVID infections are manifesting many symptoms and sometimes no symptoms at all. And even though they have no symptoms, should they come into a country, they will be able to transmit that disease within the country. So a border can't stop that from happening. What can be best, though, is to have good systems within the country to rapidly detect and respond to disease, especially when outbreaks are occurring, understanding where the transmission has come from. Now, it's true that many countries have seen importations from many different places in the world. I think Japan has the best record that I've seen of where cases are coming from. And the initial cases came in from Asian countries, then from European countries, then from American countries. And they've seen how these cases have come in. But they've been able to deal with them. And I think it's a judgment that countries make about how well they feel they can. If they just block people from coming in entirely, then yes, they won't have imported cases. But if they have good systems in the country to detect and respond to disease, they should not be worried if their borders are open that they can not detect and respond to these diseases. So the virus has spread widely throughout the world now. It will continue to spread internationally, no matter what is done, because people always manage somehow to cross borders. But if countries want to shut down completely their borders, they can probably prevent disease from coming in. But as I said, it causes a false security, because if people come in a way that's not through a legal border, they can transmit infection. And if there's not a good system to detect it, the response will be not right, and there will be an increase in transmission. So let me just try to summarize. If a country wants to close down its borders completely, yes, it can, in fact, prevent a lot of infection from coming in if it will come in. But the majority of countries already have a lot of infection in those countries, and the added value of closing down borders may be very little. And so that's why I adhere to the WHO recommendations that borders should not be shut. It's more important to keep trade moving, to keep business moving at this point in time, because we've seen that the lockdowns have severely depressed economies in many countries, while ensuring that countries have good response capacity in place. I hope that's been clear.
Brilliant, Dr. David Heymann. So for now, ladies and gentlemen, and Dr. David Heymann, for information, we have our guest of honor here with us at the hall. And yes, going live now with the Right Honorable Chief Minister of Sarawak. And also next to him is the Honorable Dr. Amar Douglas Uga Umbas, Deputy Chief Minister of Sarawak, who is also the Chairman of Sarawak State Disaster Management Committee, who's handling the COVID-19 pandemic here in Sarawak. So here he is, Dr. David Heymann. Yang berhormat Dr. Amar, dipersilakan.
Very good afternoon, Dr. David Heymann.
Thank you.
Afternoon in Malaysia. I'm not sure what time is it in your country.
It's in the morning here, so thank you very much.
Good morning to you. You have given us a very fruitful feedback. Especially, I am the chairman of the Sarawak Disaster Management Committee. We've been managing the COVID issue in Sarawak. Indeed, it is a very difficult decision. Of course, the easiest way is to lock up Sarawak from the rest of the country. But as you say, that is not practical. And therefore, your comment, your advice will be a very valuable lesson for us, because soon we have to work out our policies, our strategies to live in a new normal, to live with idea of COVID-19 still around. My only question to you is, when will we get the vaccine for this COVID-19? So thank you very much, Mr. David.
Thank you. And that's a very good question. Let me just start by saying that we really don't understand what the final destiny of this SARS coronavirus 2 will be. But the scenario that many people are using now is that this could become endemic and remain with us like the other 4 coronaviruses that cause the common cold or other infections such as TB. So if you're looking at this disease possibly becoming endemic and looking at the role of a vaccine, then a vaccine would not prevent it from becoming endemic. It would be a very important tool, and it could be used to prevent infection in certain people. What we don't, however, understand is the immune response to the coronavirus, and we don't understand what a vaccine might be able to do. Right now, we understand that there is a response to the coronavirus infection that causes antibody to be produced. An antibody is oftentimes an indication that there is a possibility of preventing reinfection. However, in the past month, there have been five people who have been documented to have been reinfected with the SARS coronavirus 2, a different strain than they were infected with originally. So we see that reinfection is possible. So the question is, if a vaccine is shown to be effective, will it be effective, for example, in preventing infection so that no one gets infected after they've been vaccinated? Or will it be useful in moderating the seriousness of infection should somebody become infected? At the same time, we don't know if 1 dose of vaccine would be useful, if 2 doses would be necessary, or if it would be necessary to revaccinate every 6 months or every year. We know for influenza, for example, that each year there needs to be a new seasonal vaccine developed, and that vaccine is then used and is useful for the influenza season of about 6 months. So there's a lot we don't know about vaccine. We don't know, number 1, if there will be a vaccine, and we don't know, number 2, if there is a vaccine, whether it will prevent against infection or only prevent against serious illness. And so it's not a good idea for a country to base its whole long-term strategy on waiting for a vaccine. What's more important is to begin to deal with the disease with the tools that we have at present. There are also many therapeutic agents being developed. There are antibody preparations being developed and being studied in clinical trials. There are also antiviral drugs being used and being studied, and all of these may have a role as well. But if this virus is destined to become endemic in populations, a vaccine will only be an added tool that can protect populations that are at greatest risk, or that can be used as the strategy is developed in a country. Thank you.
Thank you, Dr. Devin.
Thank you very much to our distinguished guests, and thank you very much to Dr. David Heymann. And yes, that's a wrap for the Q&A session. So Anita, back to you in Kuala Lumpur.
Thank you, Farah. Can you hear me?
Yes, loud and clear.
Dr. Heymann, that was very, very clear, and that was very refreshing news. I think more of this needs to be known. I think a lot of people are still waiting with bated breath on the notion of the vaccine. And I think this is news that I know Japan was one of the earlier countries as well to have started policies in learning to live with the vaccine and putting measures in place. I have another question, and it's a final one, where there was a lot of talk surrounding the vaccine in terms of what are your thoughts on governments making vaccination compulsory, either as a policy nationally, as well as in order to facilitate international travel?
Well, that would be a decision that a country would have to make on its own, using its own ethical judgment. Some countries do require, for example, measles vaccination when a child enters school. A child must have a measles vaccination. Some countries don't. Other countries don't have laws. And so I think it depends on the national debate and using ethical and other groups to understand what is acceptable and what should be done in Malaysia. Once a vaccine is available, it will be important to get it distributed to every country. And you know, there is a group called the ACT Accelerator, which is trying to accelerate research, increase the amount of research, but also making vaccines, therapeutics, and diagnostic tests available should they become available. And already this group is working with the World Health Organization, the Global Fund on AIDS, TB, and Malaria, and the Fine Diagnostics Group in Geneva to get diagnostic tests, not the PCR test, but the rapid patient test for diagnosis of antigen. This is a test that takes 15 minutes to perform and can show whether a person is infected. These tests are now being made widely available through this partnership to countries around the world, and countries can procure them for between $3 and $5 per test. So progress is being made. That's why it's important to live with the tools we have today, to get these diagnostic tests into the right testing strategy so that countries can do a better job in containing outbreaks when they occur and making sure that this virus is kept under control, but it probably can't be eliminated at present.
Thank you very much, Dr. Heymann. That was loud and clear. The message